of also P2P is to, I mean, support the healthcare system in different ways. So it says like developing Ethiopia's human resource capital healthcare education, um, and bringing Ethiopia truly to the 20th century. So if we are going to meet that one of the areas that somebody should put his money is going to be on cervical cancer. So having said that, we'll see, this is the outline of the presentation. So this is a famous saying by the Director General of the WHO, which he had a speech in 2018 when the WHO call to action to cervical say was launched. So he said one woman dies of cervical cancer every 2 minutes, and each one is a tragedy, but it's also preventable. So that was another very important event, the 2018 WHO summit in relation to cervical say prevention. So let me give you what we experience at St. Paul daily. Okay, that will in prospect will show you the challenges of cervical say in our country in terms of healthcare promotion, health promotion messages, preventive strategies, treatment, including palliative care. So here you see a 40-year-old woman who came from a very rural area, like 560 kilometers, with a late stage cervical CA, and almost, I mean, the family assembling all the resources that they have, and considering that they will be back home with maybe some drugs and surgery. But unfortunately, this patient has an advanced disease, and then she had bilateral hydronephrosis with renal failure, and she was stent was inserted, and naturally is going to not to be operated. So she was sent for radiotherapy, but the radiotherapy is not available in our hospital, St. Paul. So she was going to be referred to Kurambasa Hospital. So you see the sequence of events. Okay, here you appreciate three, four things. One is the awareness in terms of screening. The second is access. Okay, this patient she may not have access for preventive service. The third is in terms of access is the treatment. Okay, she couldn't have the treatment there and also in our setup because we couldn't do the surgery and radiotherapy is not available. So at the same time, you see the consequence of a single woman having cervical say is beyond okay the issue of a single woman. It affects the whole family. It has familial, social, okay, and also national impact. Okay, it's not only a single. The days of a single woman is not the days of, or morbidity of a single woman is not okay. Morbidity of a single woman. So the second two things they show you, even if health, I mean, there are services, awareness, okay, the level of health promotion message we pass to individuals matters a lot. Here you see, I mean, a mother of two physicians coming with advanced disease. And this is the third one is a very unfortunate nurse who was our staff, was diagnosed with stage 2A, and she was given chemo and then surgery. She recovered within a very short period of time, and she died of the disease very fast, just within 1 year and a half. So all these scenarios show you, okay, why we need to focus on cervical. Say everything is depicted here, from health promotion message, screening, treatment, palliative care, whatever, even including coming up with the standard means of treating patients with cervical cancer. So just as an introduction, globally, so it has already been presented from the previous presenter, around 660 new cases are diagnosed in 2020, and like 300 diseases minimum they occur yearly. But unfortunately, 85% of these days they occur in low resource countries. And to make it more grave, okay, it affects a very young, productive women. Okay, and the other thing, 90% of these days worldwide, they occur in low middle income countries. So to go further, I mean, on this impact of the disease, we have already said it affects 300 women in terms of the days. if we are not going to do anything, where will we end up by 2030? Modeling was done, and it shows you that annually the days will rise up to 400,000, and the annual number of new cases is projected to increase to 700,000. This is by 2030. That's why the WHO came up with a 2030 cervical elimination strategy that we will see in the next slides. So HIV is very common in developing countries. You know, HIV, a woman having an HIV, they have a 6 times more risk of developing cervical cancer. Just something to compare with the developing countries. Okay, the current status of cervical say in developing countries, especially it's important for policymakers. It reflects the status of cervical say which has been which was there 40 years back in the inner city of the US. You see the very large lag period. So fortunately, the disease could be preventable. Currently, it's said to be one of the preventable diseases using all these strategies. As I said previously, there is global commitment currently to eliminate cervical cancer by 2030 using 3 important strategies. So just these are 3 slides just to show you again to strengthen what we have already been saying. Okay, the disparities between high and low income countries in the different aspects of cervical, say, prevention and treatment. Here you see, for example, immunization. It is even from the high income countries more than by half. Okay, low and middle income countries. The next will be in terms of cervical screening. You will see almost the same picture. In terms of treatment, palliative care, also the disparity is high. I am displaying these slides because it shows you that we have a lot to go, okay, to tackle cervical C. So this is one of the forums, okay, I mean that we can utilize or exploit for the prevention of, for initiative for the prevention of cervical C. So back to our national data, we'll see the burden of the disease in Ethiopia. So this is, maybe it has been displayed by the previous speaker too. The top 3 leading causes in females, you see the first breast, cervix, and colorectum. This is in terms of incidence. In mortality, it is the same. Breast is the first, followed by cervix. This is colorectum. This is from the Global Cancer Observatory data in the same thing, but it shows you in terms of the percentage contribution of the different cancers in women. So cervical cancer stands second, even more than any other gynecologic malignancy. So in terms of the days, the number of days yearly in Ethiopia, you will have at least a minimum of around 4,000 days. In terms of treatment before the date, like 80% of the patient, they present late. That's why it doesn't give you adequate time to address, the problem in terms of surgery, chemoradiotherapy. So this is also another graph showing you the morbidity and mortality. So cervical cancer crude incidence is around 30. This high usually is 2 to 3 in developing countries. Just to highlight some of the important points, cervical cancer deaths, almost we have said this is actually 2019-20 data. And you see also here population-based cancer registry is there, it's said to be there, but from the, I shared a previous speakers concern that actually we can't really say we have a well-functioning cancer registry system. Maybe if people from the Ministry of Health are here, they can comment on that. So if that is the burden of the disease, what is the strategy to tackle it? So we follow the global prevention strategy of the WHO, which was devised in 2022. So it has envisioned the elimination of cervical cancer and to decrease the threshold to 4 per 100,000 women from 13. So you see almost a 3-fold decrement is targeted by 2030. So to reach this goal, the 90-70-90 target must be met by 2030. What are these 90-70-90 targets? So 90% of women, they should be vaccinated with at least the Gardasil vaccine. The second is 70% of women, they should be screened, preferably at two age cutoffs, 35 and 45. The third is 90% of women with early stage disease getting treatment, either with surgery or chemoradiotherapy. So if this is implemented globally, specifically in developing countries, we can significantly decrease the morbidity and mortality associated with cervical CA. So this is adopted nationally also. The Ministry of Health has accepted that approach. So what are we doing in terms of prevention strategies? These are the things that we have been doing. National Cancer Control Plan, it should be updated. It was between 2060 2022. It's not updated. Maybe there is an initiative going on. Again, if there are people from the Ministry of Health, they can comment on that. We have guideline for prevention of cervical cancer, not updated. We have adopted already the WHO call to action, and training materials are there, especially in pre-invasive screening and treatment. So we are talking about the status, taking stock of cervical cancer. So the primary aim of this presentation is going to be what are we doing actually in terms of prevention and also treatment. So the next slide, they will highlight what has been done or what's being done at the national level in terms of prevention and treatment. So this is a recent WHO recommendation. This is a standard. So now they are saying multi-agent cohort, single dose, or in some patients, two dose. So this is a recommendation. What are we doing at the national level? It was started 2018, but initially it was not multi-age cohort, which is said to be more effective. It was single-age cohort of 14-year-old girls. But as of June 2030, there was a, November 2030, there is a plan to make it multi-age cohort, but it was a little bit delayed, and we think that the multi-age cohort single dose is started in 2024. So far, how many candidates women have been reached? You can see the figure here. It's 6.5 million girls vaccinated for the first dose and 4.2 million for the second dose. So if we extrapolate this into percentage, it will give you like 80% of the target for that program. Remember, it's just for the program, not for the candidates. For that program, 80% has been made. Here you see this picture, around 84%. But if we, extrapolate to the total number of girls, it's far beyond 80%. Okay. So the other thing is, in terms of primary prevention, these are the things that we need to see at the national level so that we can act on those important, points to be improved. Do we have HPV included in vaccination program? It's yes. By the way, this is excerpted from the WHO's data from 2020 on a country profile of cervical CA for Ethiopia. So scale of vaccination program is national, and the year, as we said, is 2018. Related risk factors were also addressed. Tobacco use prevalence among young ages is around 1%. By the way, it's not really low because we have 120 million, meaning that 1.2 million are smokers. Remember, these are girls between age 15 up to 49. The other thing, condom use at the highest risks, it was assessed in 2016. We don't have recent data. So it's 44%. So you see it's really pretty low. The other thing, HPV incidence per 1,000 women is 0.2. It's not really bad, this figure. So the other issue is about secondary prevention. If you say that's current status in relation to primary prevention. So we have the pap smear, the visual methods, VLI, VIA, and also HPV testing. But at national level, what we are using is the visual inspection methods, either using Lugol's iodine or acetic acid. That is still what we are doing in terms of screening patients. So you know this the advantage, but still we have advantage. The technical aspect of this is not in the scope of this presentation. Just to show you what we are doing as secondary prevention level. So do we have a national screening program for cervical cancer as of 22? And now it is yes. The primary, we have already said, the target age group, still it is up to 49. In some countries, by the way, it has went up to even 65. So still we are setting the target too low. It could be related with different logistics, okay? So the other program guideline, it exists to strengthen early detection of symptoms. It was assessed and that was good. And there are clearly defined referral systems, even if the efficiency of the effectiveness of the referral system is not well studied, but we have different referral pathways for cervical cancer. So what is our performance in terms of cervical cancer screening? We say the primary method is visual, but unfortunately we have a very low cervical cancer screening, which is only 12%, okay? So only 12% of candidate individuals are screened with a VI method, so we have a lot to do here. So we said also the primary screening method is the HPV testing, primary HPV testing. So what are we doing at the national level? Currently, there are just pockets of initiatives to start the primary HPV testing. Most of them, they are driven by just programs. Otherwise, at the national level, because of resource constraints, still primary HPV testing is not cascaded, okay? So this is one potential area to be, to embark on and work on if there are collaborators here and at the international level. So this is a graph showing you what we have achieved in terms of screening and treatment. The overall aim of secondary prevention is to detect the disease at the early stage and treat it. So here you see we have a very good increment in the number of VIA services, but you see the treatment, the most important, when you detect it, you need to treat it. It's totally okay, a very big discrepancy or gap between the detection by VIA or by expansion of the service through VIA and the treatment, okay? Maybe like 10 years back, they were like 25, but within like 10 years, they have expanded to 50. So we need to work more on, increasing the number of treating centers for pre-invasive lesions. So the other thing is the tertiary prevention is to treat the patients when they come with the disease, especially if they give you time in terms of coming with an early disease. So at national level, where are we? This is also the 2021 evaluation by the WHO. We have a national guideline, but it should be updated. As you said, it was in 2015. So are there cancer centers, department at tertiary level? Yes, but the total number is not more than currently for a 120 million population, which like possibly 50% are going to, 50 million are going to be female. So pathology service, this is an area that needs also a very good improvement because we do only the histopathologies. So immunohistochemistry, molecular, other genetic tests which can be done hand in hand with the pathology service are not there. So this is an area also to that should be improved. So cancer surgery, we have it, but it's a very limited area. So as you said, 4 to 5. Chemotherapy, the same thing. Radiotherapy, previously we had only one center, but currently 4 functional centers are there, and we are expecting 3 more chemotherapy units to be, launched very soon. So this is the previous assessment. I will pass this one because this doesn't reflect the current status. Not one, as I told you, they are between 4 to 5. Oh, this is another maybe interesting figure showing you the number of medical staff for per 1,000 cancer patients. So radiologists, oncologists, the real radiologists, oncologists, we don't have so far, but medical oncologists at the same time, they work like radiologic oncologists, medical physicists. We have around 3 at Blackline. This was a previous figure from Blackline, but currently we are St. Paul also are having and also at another center. So surgeons, a total of 52. This is a little bit exaggerated, meaning if you say really gynae oncologist should do the surgery, then you have only around 25 gyno-oncologists. So the other thing when you think of treatment is the palliative care, as already been has been raised by the previous speaker. In primary healthcare facilities, whether it is public or private, we don't have a dedicated palliative care center. That is one area that we need to work on. And pain control and elevation of anxiety and other important end-stage symptoms of cancer should be addressed with a well-integrated palliative care system, either long-standing or in the hospital. That is one area that we need to work on, maybe with some collaborators. So in terms of training and human resource development, we have only 4 fellowship sites. As I told you, gynae oncologists who have been trained well, with structured way is only 2025. Here we would like to thank the International Gynecology Cancer Society and the GTZ, who have been working, in collaboration with the Ministry of Health and the different institutes in Ethiopia to increase the number of trained gynae-oncologists in Ethiopia. It has been actually successful. Just within 6 years now, we are achieving 25 gynae-oncologists, and I think that is some sort of success. So finally, what can we do? We said we need to take stock of cervical cancer. So we shouldn't stop there. It's not only assessing what has been done, but what should we do is the most important issue. As I said, I will again repeat it with the mission and vision of people with people. These 2 slides are going to be very important. So I borrowed this team which has been there during the conference which was held in DC. Healthy women and healthy societies are 2 sides of the same coin. So we strongly believe in this. The health of a woman is not only the health of herself, it's the family society. The death and mortality is the same thing. Mortality is the same thing. So we need to deal with it. If we believe on this, then we need to do what we can, okay, to improve the health of women. So in terms of cervical cancer, improving community awareness, one thing, even with more innovative ways of awareness raising, rapidly expanding workforce capacities through training, and strengthening the healthcare system, the existing healthcare system, as we have seen, pre-invasive treatment, even treatment of early stage disease. Another important thing is the social marketing, maybe shaping the market so that, okay, you can lower important life commodities. Importantly, here, for example, you can consider lip machines, HPV self-DNA tests. This could be somewhat subsidized also because they can be available to most women. So another thing is introduction of affordable technology into the screening. So here, home test kits for HPV DNA tests could be considered because there are different familial, social, and cultural issues, okay, which hinders women to come to health facility and get screened. If we can distribute this at community level, we are going to reach a lot of women. So especially in developing country where health seeking behavior is very much affected by cultural, social, religious, and the personal attitudes, is very important to introduce such kind of affordable technologies. So the other thing, nationally, scaling up organized population-based prevention and treatment platforms. Still, there are pockets of initiatives going on, but it should be in a well-organized way. And the government needs to create an enabling environment, including the political system. This is very important for any collaborators to work effectively in the nation. So all this, but should be those were the strategies that we need to consider, but they should consider when you implement these strategies, these 3 things are important. One, it should be developed in concert with frontline healthcare policymakers, providers, advocates, and the women themselves. Another important thing, okay, it's also for policy making, is very crucial to frame cervical cancer prevention as in the primary healthcare coverage. Okay, so it should be considered as a basic human right, and it should be considered the basic service that a woman should get. So if it is framed inside that, then we will reach many women. The other thing is the problem in developing countries, we usually tend to prescribe things like in the form of, okay, services, care, whatever, okay. We are not considering the socio-cultural context of the society. If you come up with some form of, for example, preventive strategy, like VI, really, does it really work in the social, cultural context of the society? That's very important. So in developing country, any initiative should always consider these things: social circumstance, personal, cultural, structural, and economic barriers, indirect access to health services. So these are the reference utilized for preparing these slides. And thank you very much.